Welcome, everyone. My name is Kelly Lyons, and I'm a professor in the Faculty of Information with a cross appointment to the Department of Computer Science at the University of Toronto, and I'm a faculty affiliate of the Schwartz Reisman Institute for Technology and Society. It is my great pleasure to welcome all of you to the inaugural session of the Women in AI Speaker Series, a collaboration between Schwartz Reisman Institute and Deloitte. The purpose of this series is to convene leading female researchers to share knowledge and mentorship opportunities for women across the technology sector with a particular focus on artificial intelligence. Participants will explore the development of new technologies and approaches and insights into cutting-edge research from the perspectives of our esteemed guest speakers. Before we begin today, we want to take a moment to acknowledge the land on which the University of Toronto operates. For thousands of years, Toronto has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit. These and other Indigenous people across Turtle Island developed complex and effective governance systems based on respect for all life and the intelligence of the natural world. Today, this land is still home to many Indigenous people who are working to reclaim their rights to self-determination and self-governance, and we are grateful to have the opportunity to live and work on this land. Although we may be all joining from different places today, we encourage you to reflect on the history and relations of the land that you live and work on. Before we move into today's talk, I'd like to introduce our collaborator in this series, Aisha Green. Aisha is a senior manager at Deloitte's AI Institute focused on AI literacy and adoption. She is passionate about fostering partnerships which advance research and innovation initiatives and has worked closely with early stage entrepreneurs to commercialize medical devices, therapeutics, and information technology applications. Welcome, Aisha.
Thank you, Kelly, and good morning, everyone. It is my pleasure to kick off this event, and on behalf of Deloitte, I welcome you to the launch of the Women in the AI Speaker Series. When we embarked on setting up this series, we were driven by inspiring the growth of future generations of AI leaders. Based on recent study from the World Economic Forum, despite talk of greater inclusion, women's representation in tech-related professions has declined 32% since 1990. As of 2021, only 22% of AI professionals globally are female, compared to 78% who are male. This accounts for a gender gap of 72% yet to close. Today, we are here to set the stage on making change that is actionable to really reduce this diversity gap. Our hope is that conversations that you will hear throughout this series and the networks that you will begin to foster will also help to change and make vital change across this sector for both women and allies. With that, I hand it over to you, Kelly, to introduce our first esteemed lecturer of this series.
Thank you, Aisha. Just a few quick notes before we begin. The session is being recorded. Our guest speaker will speak for about 45 minutes, and then we will take questions after the talk. During the Q&A, we encourage all participants to use the raise hand function in Zoom. I'll call on you, and then you can ask your question with your video on. Without further ado, it is my tremendous pleasure to introduce today's speaker, Anna Goldenberg, a professor in the University of Toronto's Departments of Computer Science and Laboratory Medicine and Pathobiology, Varma Family Chair in Biomedical Informatics and Artificial Intelligence at SickKids Research Institute, and a CIFAR AI Chair at the Vector Institute. Anna received her PhD in machine learning from Carnegie Mellon University with a postdoctoral focus in computational biology and medicine. She did her postdoctoral training at Penn Center for Bioinformatics and the Donnelly Center. Her research focuses on developing and deploying machine learning models for clinical use in healthcare, including risk prediction and early warning clinical systems. She is also strongly committed to creating responsible AI techniques that benefit patients across a variety of conditions. Through her work in AI, Anna is leading the way when it comes to the future of healthcare, and it's our very deep pleasure to have her with us here today. Anna, the floor is yours.
Thank you so much. I'm just going to have my big face here to say thank you for inviting me. It's a great pleasure, and especially it has been my passion to try to to help and lead and bring in more women into the field, because we always benefit from diversity and of opinions and backgrounds. So without further ado, I will jump into sharing my screen and the talk. Today, I want to talk to you about designing machine learning for deployment. And I have two goals in mind. One is to introduce the many applications of machine learning in healthcare that you might not have thought of or heard of. And the other is to help think about all the problems that might come up as part of integrating machine learning and AI into healthcare. So you might have heard of several of these applications already. The surgical robot is in production. It uses AI for navigation, and it's been in use for several years. The automated planning and radiology, and in general, radiology is the field that has likely benefited the most from AI. This is actually a tool in particular that was developed here at UHN. And the detection of skin lesions. And the detection of skin lesions was first published in 2017. Over the last 2 years, it has been starting to be implemented in remote clinics, right? I think the holy grail of AI in healthcare is that not only we were able to help patients here on the ground in Toronto and in major metropolitan centers, but that we can take the standard that AI brings to healthcare and put it in places where training is difficult, expertise is sparse. But there are so many problems in healthcare where AI can help. So this is one of the first projects that I have done in collaboration with Jonathan Wasserman, an endocrinologist at SickKids. And the goal was to detect or to assess whether a thyroid nodule is likely to be malignant. So the current procedure for thyroid cancer detection is to do an ultrasound, and if there's a suspicion of malignancy, to do a biopsy. And again, if it looks like it's likely to be malignant, then there is a surgery. But I don't know if you know that 67% of surgeries later find out that the nodule was benign. So 67% of surgeries might not actually be necessary. Sometimes they resect half, but sometimes they resect full. There are definite consequences to this invasive procedures. So Jonathan and I collaborated on a model that would predict the likelihood of malignancy. And basically, we developed a model. It was based on random forest for those of you who do AI already, but it's a little bit more complex because we didn't have a lot of data, so we had to be a little bit clever about this. But we can reduce the 67% to 30%. Being on the conservative end of making the prediction, and that using exactly the same data. I'm sure this can be much improved if more data is incorporated into the model, but this model only took the data that the human uses and developed a method that has this much better rate of detection. Another example is an anomaly detection, the detection of cancer in kids who are predisposed to having cancer. And in collaboration with Dr. David Malkin, an oncologist at SickKids, we are working on Lee-Fraumeni syndrome. Lee-Fraumeni syndrome is a cancer predisposition syndrome. It's often characterized by a mutation in a particular gene. And this if a person has this Lee-Fraumeni syndrome, a cancer can occur at any age and almost in any body organ. So there's around 80% chance of getting cancer over a lifetime and almost 40% chance by the age of 25. So the only hope of the positive outcome is to detect it early and to treat it early. The issue with this is that it's a screening procedure. And so the cancer tends to be very, very small in the body. And so together with my student, Abi, we developed this augmentation procedure where we can take an image and we can say, okay, what should the person look like if they didn't have cancer, a healthy image. And then what we do is we compare the image of the person that we get from whole body MRI and the image that we would have generated based on their assumption that they're healthy. And then we compare these images and we can detect whether and where there are anomalies in this image. There are other projects in this domain as well. For example, in trying to predict how likely the person is to get cancer before the age of 6. And that project is also fairly complete as well. Another area where we can make some difference is optimizing when and which tests to administer to patients to get the most information. So the policies in general are somewhat dynamic. So obviously when a person is in critical condition, there is more testing, but it's usually based on the clinician noticing that there is something wrong. And of course, there are so many patients and they might not notice, or they might do a lot of testing with the introduction of potential negative events where the tests are not really needed. So the idea is to optimize this process and create procedures for detecting when it is important and to take which test. So we have developed a method that was actually, we have shown that it can reduce the cost of taking the test by 38% and increase the information that is available through this fewer tests by threefold. And another type of problem that we actually are working on solving for the last 4 years is a great collaboration with a critical care unit at SickKids is detection of cardiac arrest. This is the critical care unit at SickKids. This is a slide that I got from the former head of the ICU. And what you see here is that there are a lot of people, but also there are a lot of monitors with a lot of information on them. And people have to sort of keep track of all this data as it's streaming, because what if something goes wrong? Also looking at the patient, also helping out. So regardless of the fact that there are so many people in the unit and catering to every patient, there's still so much information that is very hard for a single human to process. And indeed, Peter Lawson often compared the amount of information in ICU unit at any given point to the Niagara Falls. It's about 200 cubic feet per second versus 200 bytes per second of information that we get as a throughput. So the goal was to take the patient, take all of this information that is already being monitored and synthesize it into the risk assessment, a prediction of risk. So we actually had this various measures, the heart rate measure, the respiratory rate, the blood pressure measures, and the oxygen measures. And we had 259 instances of cardiac arrest, and we had a bit over 1,100 ICU patients that did not suffer from the cardiac arrest. Of course, they're not normal in a sense of being healthy, because they're in ICU, so something is wrong already with their health. So the population, as you can imagine, is quite heterogeneous. So we had to define all these ranges in terms of what is considered a pre-cardiac arrest window would be the 2 hours in consultation with ICU. 5 hours out, we have considered to be the signal range, which is non-arrest signal range. And we have combined all of this information, and we have trained one of this, one might think, involved deep learning systems. And the reason for doing that is because real data is very, very complicated, and it's noisy, but it's also has a lot of missing data, right? The probe falls off, or maybe there is a blood draw, or maybe blood draw shows up as an artifact in the signal, or maybe there is a person is coughing and that shows up as almost an arrest magnitude signal. And so what we have done was we have various masking that's incorporated, and then we have a weighting network that actually helps to calibrate the system to not be dependent and swayed by this various noise signals. And we have roughly can detect cardiac arrest in about 70% of the individuals within the 2 hours before it happens. So this is early detection that can lead to prevention of a cardiac arrest. Now, you might say 70% is not great, but what happens is that we actually can give this information to the clinicians, and it's additional information. So for some of the patients, they might already know, but for others, you can prepare a team or even introduce some preventative measures to help avoid a cardiac arrest. And of course, in any patient, if we were able to detect it early in any patient, it would be beneficial. So 70% is actually quite good. This is the tail where we predict the cardiac, where we say that the risk is low, but the patient actually suffered the cardiac arrest within the next 2 hours. But notice that this is a prediction for every single 5-minute window. That's why there are so many, 2,000. So for some of the patients, we cannot actually predict way far out. We can only predict much closer. This is what this tail indicates. And of course, it's important not to signal everybody is having a cardiac arrest, because then there is a burnout, and this becomes useless. The system becomes useless. And finally, another project that I wanted to mention is an operational improvement, right? So a lot of the hospital systems actually need something different, just to tell the patients, and to tell how many patients are in, say, emergency department, which is this project. So this is a project that we have in collaboration with Devin Singh in emergency department. And the idea is that if we can predict the patient volume to need to be escalated, not necessarily the exact numbers, though we do indicate it, if we predict that it needs to be escalated, each escalation level already has a procedure associated with it, saying you need to open another unit, you need to get more staff, et cetera, et cetera. And we make a prediction over the next 24 hours. And so that they can actually prepare themselves for making these changes or requesting these changes, so that all of the transitions go smoothly. This is what the data looked like. We had a couple of years of patient census data in the emergency department, and you can see just how non-stationary this data is. There were some patterns before COVID. COVID changed everything, and maybe you don't expect it, but we had much lower numbers in the emergency during COVID, especially in the beginning. And this was the case because, first of all, it's a pediatric hospital. So there were, as you remember, there were a lot fewer kids getting COVID, but also people did not want to go to the hospital for being afraid to get sick. And so there were a lot fewer reasons that people would go to the hospital in the beginning. So the situation has changed, and this we actually built a model based on the pre-COVID data and during the COVID data. And here you can see the observations and how the model is mimicking them and making predictions. So sometimes it's higher, but a lot of times it's actually on par with the change in the that will have a impact on the workflow, the clinical workflow. And I think that's the most important thing that we wanted to address. So sometimes, I don't know why, yeah, okay. Sometimes I'm not able to switch slides, but it's okay. So basically, because this system we planned to implement at the hospital was built with a specific purpose to be implemented at the hospital, we actually had to do a lot more testing than one would with respect to if they just wanted to publish a paper. So we had to figure out how far in advance can we predict? Can we predict 2 days out, 3 days out? And we have noticed that really 1 day out before we retrain is important. And the reason why we have to retrain basically nightly is because of the non-stationarity related, which started with COVID, but it still is not completely normalized. So in the emergency patient system, we retrain it nightly. How much data do we train every time? So we have a move-in window of 360 days where we have tested various amounts of data and found that this is the most helpful. And how close to predict to stop training? So can we predict we need some time for validating the model, because if the model is not working on today, then there may be something wrong with the model, and then we shouldn't be using it in the production tomorrow. So this is the idea of that we tested here, and we can stop training 1 or 2 days in advance to have the next day as validation and then predict the day after, but not further than that. So I just wanted to, these are sort of all the projects, but I wanted to talk to you about the lessons that we have learned. So as an academic, I've had a certain sort of workflow before I started thinking about building machine learning models for deployment in healthcare. And there are quite a few steps, but this is nothing actually compared to the number of steps that are required to make sure that the system is useful in healthcare. So you can see here on the left is the small workflow that I've been using and optimizing the whole time just before we started sort of trying to build these models for deployment. And the reality is there are a lot of nuances from capturing the data at point of use, right? Because when we start, when we use data for not in real time, we usually process it, we scale it, we make it very nice. When you need to make a prediction for the next hour or for tomorrow, oftentimes all of that has to be automated. And a lot of times you don't want to pre-process it too much because potentially it will diverge from the kind of data that you are likely to see. So you want to capture it as raw as possible and incorporate and build a model such that it can work with this raw data. And then there are a lot of the steps for testing. So the silent trial mode, we have several models running in the silent trial mode, including the emergency department census. This is where the model is running in real time at the unit, but is not affecting the workflow yet, but we can actually collect the data and information about how it's doing over time. And at some point, some of the models started deteriorating after a few months, and we were trying to understand why and realized that it's due to non-stationarity that was beyond what we expected. So these are all the lessons that we have to learn and we have to adapt to before something goes live. And of course, a very important point in green, and we as machine learners not necessarily learn this, but we have to envision the user interface that would be very efficient for clinicians, right? They're very busy. They already have a lot of time sinks based on some health systems that are not necessarily optimized for their usage. And when we start introducing new tools such as AI, we want to make sure that they are very seamless for the technology. So they don't necessarily blame AI for it not working well, right? We want to make sure that the tool is visually very compatible with our workflow. So I don't know if you know, this is the data from 2020, but the proportion of papers, the point of these graphs is that the proportion of work that is being done in AI and healthcare is not growing with a scale that the AI papers are growing in healthcare. And that is very sad. And so we started thinking about what are all the reasons why this is happening. And the reality is that sometimes there is an institutional lack of readiness, right? People say, oh, we have data, don't worry, we have tons of data, but the data is just not in the format that it can be readily used for an AI system. There's a lack of integrative pipelines. Even if the data is all digitized, there may be a dependency on people who have to do the integration who are just not available. The governance approvals, this is a big deal. If the institution has never integrated such technical systems on a regular basis, there needs to be a new pipeline established for approvals, and that often takes a lot of time. And not necessarily clear prioritization of the tasks, right? We clinicians and AI scientists may develop jointly a project, but there may be no priority at the hospital level to implement it. And of course, there's so many things still that we have to improve in the AI and the technical world. So I will briefly mention some of these AI issues and challenges. Here's an example, lack of context. So a patient with asthma has pneumonia and is treated more aggressively. This is what already happens in the units. But that means that there are fewer patients with asthma that actually have adverse consequences from pneumonia. And the system who only sees asthma, fewer deaths from pneumonia, says that it's actually beneficial to have asthma. Right? It doesn't have the context to say, actually, there is a policy already in place that treats them more aggressively and condition on that policy to adjust for this effect. So these are some of the issues that we can notice ourselves with a common sense sometimes, but sometimes we cannot, right? Because it's much more clinically involved. A problem that we had in my particular case, where we have built a system for detection of thyroid cancers. And in one case, we had a validation set prospective set where we tested it. And there were 3 malignant patients, but we missed one. And we were very surprised because the system was very confident about this patient. And I asked the clinician, and the clinician said, oh, it was a boy whose father also had thyroid cancer. So I knew that we had to test it more thoroughly. And of course, the history was not part of our data set. So there was no way to actually use that to make a prediction. So this is the issue with the lack of context, that the systems will never be reaching their potential because they simply don't have enough context as part of the system. This is an example that from the San Francisco medical system. We had an exchange at some point, and the data science team from there said that they've implemented an Epic tool that predicted no-show appointments. And basically, if the appointments were no-show, they decided to double book them. But what happened was that they overbooked all of the appointments for African Americans and very low SES system, and they couldn't understand what was happening. And then they looked into the model directly, and they found that the model was just based on race and SES. And of course, this is a travesty, and they completely fixed it, and they re-implemented the model. When they contacted Epic back, Epic said, well, actually, you know, it's up to you how you implement the model. So they didn't even take the responsibility for saying this model is actually not good and it should not be part of the suite of models that are available. So this kind of stories make me really worried about people who didn't necessarily think about the responsible use of AI before offering it to others. I think I'm actually just making sure that I still have time. So what are we learning about? There are many systems. These are somewhat anecdotal cases, but there was a system that was learned and it was published and detecting pneumonia. But in the end, there was a token for pneumonia. It happens all the time, actually, that there's a system when the clinician suspects that the person already has the disease, they send them to a different machine. And so there is a difference in machines. And so what an AI system learns is actually the difference between machines, not the difference from pneumonia and not pneumonia. So these are real. Another example from our stories, even though we are trying to minimize the positive rate of cardiac arrest detection, you see we only have 100 cases per year. And this is 30 beds and the system is running all the time. So this is trying to estimate the risk every 5 minutes of every day, every week, every month, every year. So that's a lot of times that we are estimating the system. So the reality is, even if we have just 1% of false positives, it means that there is a 30,000 roughly false positives per every 100 of true positives. Right. So we went back to the doctors to say, what do you think of this? Is this too many alarms? And they said, actually, we think what the system can help us detect is deterioration towards any critical event. And in reality, this is exactly what we are preparing to test in the unit, is deterioration towards any critical event. So that goes back to, are we asking the right questions? If we are trying to predict a very, very rare event and it's going to be tested all the time, our systems might not be the best tool for that. But there are many other ways to use them to summarize signals and to aid clinicians in that way. One actually question that a student of mine is working on, and I don't think it's worked on enough in the field, is this feedback loop problem. And the feedback loop comes up when a machine learning model is deployed and it's actually affecting clinical decision. So the clinicians make mistakes, the system makes mistakes. We can think of them as somewhat independent before the system is deployed. But once the system is deployed, some of the clinicians might adopt the system's decisions and it's an erroneous one. So what happens when our P of Y, when our distribution of the outcome actually starts getting affected by the system itself? It will make it look like the system is doing really, really well, but in reality, it's deteriorating. So this is something that we've published. Actually, there's another paper on this for how to prevent it and what affects this feedback loop problem by Alex Adam in my lab. And of course, the deterioration, the false positive rate grows slower if there is less trust in the problem, and higher, faster if there is a blind trust in the model. But somewhere in between, it's still deteriorating. And we have to take that into account, and we have to monitor for this. So there are many, many other issues. We are not optimizing the right objectives. We are not determining conditions under which the model is valid. We actually had this in the lab. Even though we are fully aware of these issues, we had developed a model at UHN on the Ontario population, and we used a hospital from Montreal for validation. And it turned out that it was in the hepatology space. And it turned out their population was quite different, actually, with the kind of the comorbidities they had, even the age that they had this fibrosis forming. So it turned out that at some point the model was not performing as well, and we looked into the errors it was making, and of course it was performing exactly the same as it did here on the UHN cohort for the patients that had the same characteristics, and this is normal to expect, but people don't necessarily test for that when they are not thinking of deployment, and that's a very important point that needs to be enforced all the time. The model may be using too many resources. It might not be possible. The evaluation may be inappropriate, etc., etc. I'm happy to talk about this ad nauseum. There are a lot of problems that we are considering, so I'm going to try to wrap up, but I want to just tell you that we have started, even though my background is in machine learning, we have started collaborating with systems and human-computer interactions people directly to start building these pipelines for integration into clinical care. So this is a pipeline for ICU that we call Lifeline, and this actually takes the data from the bedside monitor. It was built on Trillium, so we are re-engineering it right now, but on Trill, sorry. We are re-engineering it right now, but the point is that the data goes directly from the monitor into the system, into the inference model, and into the interface. And we actually had to design the interface in a very different way for the specific problem, because we're producing a risk estimate, and nobody is actually recording risk estimate right now in critical care. So our goal was to assess how good is our risk estimate. So we have a screen that first assesses risk estimate before the system starts influencing the person's thinking. And then the person is able to actually pull the risk estimate to where they think the risk is or should be. So for each of this sort of additional risk estimates that are corrected, we actually have comments and annotations to say why they think the risk is different than what the system predicted. So this is a small illustration of that. I'm not going to go through this, but if somebody wants in the end, I'm happy to show. The point is that it's a very, we have to think through and design this completely new system, because the labels that we use for making the predictions, for improving the system, are actually not available. They are not there. We're using an auxiliary task of cardiac arrest to make this risk estimates. So to summarize, undoubtedly, there are many successes in AI in healthcare. More and more applications are getting approved by FDA, and here in Canada by Health Canada. And there's a lot still to be introduced, but it's really so much to be done. And you can see there are so many pitfalls where ML can go wrong. And my worry, of course, is the AI winter, where somebody produces a system that's not robust, it hurts patients, it harms patients, and then the whole field is sort of thrown back into the dark ages because of this. So we have to be extremely responsible, extremely practical, and working very closely with the clinicians to make sure that the systems works. Just to give you a sense, I've mentioned a few projects, but we have many more. Some are the medical imaging projects, some are, we actually have 5 projects now in the wearable space, because I'm very interested in what happens outside of the hospital and how we can use this information in the clinical space. Because right now, wearables are sort of used outside in the healthcare domain, and in the clinic, we don't have the view into that, but it would be very nice to figure out how much of that data is actually useful. So this is a lot of the wearable projects, and one that we have in submission right now is the COVID detection project, showing actually that a lot of the papers that were published in a COVID space using wearables are not as good as they claim to be, because they didn't use the right design for the machine learning tool for the evaluation of the tools that they have published. So yeah, lots of different projects. I'm not going to go through them now. If anybody asks, I'm happy to talk to them. There's so many interesting questions that still need to be answered. So for example, different clinicians want to see different explanations of the same thing. How do we show different people different explanations, right? We are talking about explainable AI. This is beyond that. What is the best way to interact with clinicians to prevent the overtrust in the model? How do we give them the information and the data for that? Continual testing, right? We would like to update the model, but how do we make sure that the model is not sort of over-secure due to this feedback loop? How do we make sure that it changes over time with the data because of all the biases, etc., and many others. And with that, I would like to conclude. I would like to thank you for listening, and my amazing lab, without whom none of this would be possible, and of course the funders that have been generously funding the work that I have presented. Thank you.
Thank you so much, Anna. That was really exciting. I'm really pleased to start our discussion period. I could already see questions popping up in the chat. I'd like to just start with the first question because I feel I have that opportunity. Why would I pass it up? I saw at the slide at the end. Obviously, you've done have so many projects on the go. And the slide at the end, you listed your team, and many of us are building and managing labs and teams of people. And I'm wondering if you have any suggestions or tips that you could pass along to those of us in those positions who are working to build a team, to lead a team. How do we keep people motivated? How do we ensure that people have the resources they need to be successful in their own research, their own work, but also contribute to the ultimate goals that you talked about for your lab? Do you have any thoughts about that?
So I have to say that working with my lab is probably the most rewarding experience that I have in my workday. So there are several ingredients that are ever present. One is the passion, sort of, about the projects. The projects that I propose projects to junior students, but I want this more senior students to come to me with their own projects, and my goal is to support them and just to help them and to make sure that they're not stuck, but otherwise to give them the independence to work on the projects that they want. But the point is that the projects that I propose, sometimes I say, this is why we have to do this. The world, has overlooked this problem, and everybody will suffer. And so in the end, the passion that I have for the projects usually is quite contagious, and the students pick it up. And in the end, I never force anybody to work on the projects they don't want to work. This is useless, especially in academia, they're not paid enough. So it's really about what are they passionate about. What I try to tailor all of the work that the people are doing, or suggestions of the projects based on their strength, based on what I've seen they're excited about. There are people who are more interested in more theoretical projects. There are people who are more interested in more applied projects. So we really sort of try to make sure that everybody is satisfied with what they invest most of their time at work into. And and I guess I just really care about students, and I make sure that they know it.
That's wonderful. Thank you. I see that Ishak Ahmed has his hand up, so I'll pass it to Ishak. If you have questions, please use the raise hand function and I will call on you.
Thanks, Kelly. Yeah, and a fantastic presentation. All great work. I was just like listening to your talk and I was like telling myself like how inspiring this work is. I was particularly intrigued by the one of the problems that you mentioned, that AI algorithms do not often understand the wider or broader context of the problem. I think that's the number one problem that you mentioned. I wonder, like, what are your thoughts around how to overcome these problems? Because for understanding the wider context, scholars from other disciplines, for example, in social science or communication, they conduct interviews or ethnography. Is there any way that we can connect those methodologies with the machine learning to find something which may help the system to work better? And I was wondering how that would look like in a place like a hospital where this artificial intelligence or machine learning algorithms are deployed through these technologies. Do you have any thought around that?
So we do have sort of people who are working with cognitive behavior that we include in some of our projects. But I feel that their role is somewhat different. It's to assess the burden of the tools and to figure out if there's a way to improve the tools based on that. The context that I'm mentioning, if the data is not there, there is no way to incorporate it. So we have in some of the units, not so much in Canada, but there is a project called the Black Box in the operating room, right? This is Frank Rudzic is leading it on the technical side, who is also our colleague at U of T. So that project, they're able to sort of observe the situation as it's happening and instruct the people who are working on it at the time or later about what can be improved, etc. But they see the whole situation with the video cameras. We don't have that in so many of our projects, and it's just not allowed, or the patients are not comfortable, etc. So we really have to rely on the clinicians. But in one of our projects, the one that I have mentioned, that we have done with Fanny about this tool that's capturing the risk, and we are trying to get these labels for the risk estimates. We are actually working on a continual learning tool in the AI space to incorporate that into improving the model. So even if we don't have the information about why necessarily the clinician picked a different risk, we can actually improve the model by incorporating those annotations as a part of a continual learning system. Now, we have to be careful not to overfit to any single clinician, but this is what it is. I think in the future, there will be more data captured and more of it consequently used in for building tools, and they will keep getting better for that.
Thank you. I see Aisha. I know I'm not ignoring the people in the chat, but I do see some hands up. So I'm going to go to Aisha's hands up from Deloitte.
So first off, thank you, Anna. Really appreciate this talk and also giving us your insights in some of the work that you've done across your lab. So would like to sort of return to that remote monitoring and looking at how you are looking to integrate that within sort of workflows and processes within the hospital, because that is really sort of the next frontier on not only reducing cost across the healthcare system, but also a new frontier of innovation. Would like to get your thoughts on what do you see as new parts that we could monitor and ways that we can integrate within the healthcare system?
So I'm very passionate and very interested in this. There are two parts. One is sort of monitoring once a person comes back from the hospital. So that's already being done in some cases. They get in an iPad and they have a monitoring system for either the heart or something like that. There's been innovation in the sort of device space in this area where people can wear these devices to monitor their heart at the sort of the clinical level. I'm more interested in the sort of the wearable space, and this is for me, this is on the preventative front. So this is to give the patient more agency for when they interacting with a clinician, right? How does this happen right now? The patient comes, they say, well, I've had some of this symptoms, and the clinician says, you're fine. Yeah, you're doing fine. And, or they're saying, well, but did this happen? No, okay, well, maybe take Tylenol. So, unless it's a very serious thing, and then, but in a lot of cases, one of the things that affects the symptoms and the perception of the symptoms is stress, our stress, right? I actually had I was sick, and I realized how much stress actually was affecting me on a physical level. So there are some conditions, including cancer, where you get affected on a physical level from just being stressed about something, work or health itself. And so that information is just nowhere to be found. It's really difficult to communicate, and the clinicians do not know how to integrate it. So the projects that I am now working on, we have 4 or so projects, very active projects, where we are trying to assess stress through the wearables so that you have some quantitative signal to show to the clinician that they understand of how to interpret the stress. We've started, we sort of working on our first paper in that area, but I think there's a huge field and huge potential for innovation in that space. How do we actually take a lot of this information that happens outside, and that is essentially a person is still healthy, right? There are no other symptoms other than this, and take this and bring it in a concise manner back to the clinician. I don't think this is being done except for, like in some cases of arrhythmia, that people who experience this, they can come and they show and this works, but very, very few cases where it happens. So there's a lot to innovate, but to understand the signal, we need to understand the signal first, because there's a lot of, the signal measures and represents a lot of things. So stress, exercise, all kinds of things. And so we have to, this monitoring will only be useful in a clinic when we are able to distinguish between what the other nuggets that would be helpful to the clinician from the rest of the data that is just not clinically relevant.
Thank you for that, Anna. I know the chat is going really buzzy right now, so I'll probably turn it back to you, Kelly, because I know there's quite a few questions that are coming through.
Wonderful, thank you. So Zoran, you have a few questions in the chat. Would you like to ask one of them?
Sure. Can you hear me?
Yes.
Yes. I'm sorry to impose. So the issue of data is something that I've actually struggled with consistently. I'm in an entirely different field. I'm in the financial services sector. But have you built any tools, or do you allow patients to label any of their data? Because that's sort of, I think, one of the an interesting frontier, because patients know how they feel. To your point regarding stress, for example, and so people know inherently when they're stressed. They have the physical, they have the psychological symptoms, and if they could label their own data, that might actually be helpful too. The second part of my question is, and this is kind of more implementation, which deals with the stakeholders that have a vested interest in retaining the status quo as in terms of workflows, and who actually is responsible for the budget for this. And when I say budget, I mean things like development, maintenance, testing, and implementation, because I have, through my career, found that we have built some very powerful tools without spending enough time on defining the problem. And then the technology is not used effectively and invariably wilts. To your point, your concern about something blowing up and someone misusing the technology and it being tainted and people just throwing it into the trash bin. One of the ways to mitigate that, of course, is to have more of a process around and an involvement with senior management and having them invested in this technology as both a budget-saving tool and also as a diagnostic tool that assists practitioners on the ground. And one final question: which is, to what extent have you considered rolling this out to patients? And what I mean by that is, one of the problems with technology today is this myth that all this data and this AI is going to enhance the individual's personal agency. And I think consumers or patients themselves see very little of what I would call the trickle-down impact on their immediate lives of this technology. And until they start to do, you may not see the kind of adoption that I think you hope for, given, quite frankly, given the amazing tools that you're building. So that's
Great.
a multifaceted question, so I'll leave that to you.
Go ahead, Anna.
So the first question was about giving patients a chance to label.
Right.
And that there are multiple environments in which we collect data. So there's a population study with the wearables where the patients are labeling their own data. So we have the surveys that go along with all the wearables, and they mark stress at various levels. And there are actually different kinds of surveys and questions, and they're able to tap their phone. So we have a wonderful study. It's called BUMP. It's a better understanding the metamorphosis of pregnancy. This is the BUMP study. I absolutely love the study, and it's a collaboration with Stephen Friend, who is a phenomenal scientist and has started this study. And there they actually can tap if they have emesis, if they're throwing up, if they are not feeling well, they can tap their phone, their watch, or enter some information on the phone. And so we have a lot more data and information that is connected to 3 other wearable-like digital devices where we are collecting data. And we already are seeing that there is so much information and that we can correlate with that data, and it's so rewarding. It is so rewarding. Now at the hospital, the data works like this. People come into the hospital, something is done, they leave, and then we get the data. Or the data is being collected somewhere in the background by nurses. So the patients do not have any input into the system to label any of that data. This is really done by clinicians and nurses. So it's a very different environment. And I think that primary care potentially will be a much more, much better suited environment for interacting with the patient and labeling, as opposed to the tertiary care such as hospital. So this is something to think of, but completely agree with you. How do you give agency back to the patients for them to interact with the healthcare system in a more productive way? I think that AI and technology and HCI especially can help in that regard. With respect to the budget, funny you ask. The budget is, of course, is always it's always a bit difficult. Our hospital has made AI a priority, and so we have a special fundraising and independent fundraising stream, and a lot of the funds that we are using now for this initial development and deployment comes from through this fundraising efforts. And I want to thank everybody who has donated money for the purpose, because otherwise it would not be possible. But in the end, it becomes integrated with a system. So IMT, the IT, the medical IT that is keeping the systems alive will be using the system. We will pass these along. And so some of the operationalization will have to happen through the existing structures in the hospital. So the hospital will have to support it, and they know it. And so there are a lot of efforts, and so trying to understand how to do the budget. It's not, we are not there yet, but the hospital also will have to support it since they have made it their priority. Other question, I saw your question in terms of the user experience, one of your questions in the chat as well. We don't have patients now interacting with these tools yet. So their experience, or they're not live to the point of affecting the clinical workflow. So the patients are not actually benefiting from them yet, because we're still in the silent trial stage. I know that Devin Singh, who is a phenomenal clinician that I work with in the emergency department, he has developed a big screen where he shows how much time a patient has to wait. If any of you have gone to SickKids with your children in the past, you would have this big screen where you see how much weight and where the weight is, etc., etc. And that has been extremely useful for a variety of patients, just so you know where you are. And but also I think it definitely improves the user experience in that sense, in feeding the information. But some of the tools that I talked to you about, they're still not impacting the clinical workflow to have the patient benefit.
Thank you. Great questions. Now, I noticed that there's a point in the chat from Ali Elawad about bias due to machines themselves. Ali, did you want to elaborate on that or ask a question about that?
Yeah, actually, that's a good point. By the way, very great presentation. And really glad to be here. I've actually seen that quite a lot in the world of cameras, right? I do a lot of work in computer vision, and one of the things that I'm seeing is the bias in, you know, the images that are coming out of the original data set that you collected, or and you receive it, you build a great model, but you go to put it in real life, and you know, objects in the wild, they act really funny, and then you have to retrain. So that idea is spot on. I was actually very curious to know if you've tried some of the methods of computer vision without actually being able to detect the identity of the patients in the sense that these new cameras right now, or I would call them sensors, that they do mask the identity, and they kind of show you a silhouette or a flow of a person, and it's intended for that purpose, right? Where you don't have to deal with the privacy issues, and you still are able to get your analytics. And we're actually working on a project related to hand hygiene, but the underlying technology behind that is using one of the sensors that mask inherently the identity of the team, and it looks like just a silhouette moving in an area, but the model is trained to understand if the person is standing, sitting, and all type of motions.
So we don't have projects directly that use video streaming, but black box operational model at Unity Health that Frank Rudich works on. That model does, I don't know if they're using the new cameras or they are doing it themselves. The funny thing is humans find a way to be seen, right? So you can see some just wear a red cap, like nobody else in the unit is wearing the red cap. It's just
yeah,
is wearing it. So you know exactly who it is. And so this, I mean, we'll go a long way to be able to really truly mask the identity of people. But I've seen the black box model where they do the analysis and they mask the people, and I think I found it quite effective. So it definitely does happen. Yeah.
Great. Thank you.
Thank you. Sai, I see your hand up, but I'm going to go to Ji-hyun first, who had a question early on about correlation and causation, and then I'll come back to you, Sai.
Hi, can you hear me?
Yep.
Okay, so I'm just wondering if AI is only useful when you have quantitative data, and also related to that, can they only detect correlation, and what does that mean for causation?
So there's a subfield that spans multiple actually fields, right? It's between statistics, philosophy, and computer science, where we do causal modeling from observational data. And in fact, we do have several projects where we try to build causal models. So one of such projects was on COVID, together with the Unity Health again, to try to understand the relations between parents and children during COVID, and whether there were any predispositions, but also what was affected. It turned out that the routines that parents were able or unable to set during COVID were at the crux of sort of a lot of the dynamics that happened in families. And we did that by building causal inference models. So we don't work with causal models all the time, because sometimes there's not enough information, or the question that needs to be solved is a prediction question, and the sort of the causality of it is less relevant to answer the specific question. But we definitely have more and more projects right now that involve building new causal models, because for time series there's not a lot, unfortunately, but also just working with causality as well. It really depends on the task at hand and the questions that we are trying to solve.
Thank you. So
Thank you.
Hey, Anna, I do not have any specific question. I just want to take this opportunity to say hi to you. I think you still remember me. So
Yes,
yeah, it's great to see you again and listen to your lecture again. It's nice presentation.
thank you.
it's nice. Also, I noticed there's a couple questions about AI and mental health. So I wonder if Monte Angel Richardson would like to ask their question. It has to do with you had mentioned, I believe, one of your projects on mental health projects. Can you elaborate a bit how that's AI has been applied in those contexts?
So we don't, I guess mental health is a sort of who knows where the boundaries of that are. The projects that we have right now are mostly focusing on stress and trying to detect stress out of there. So we do have mental health surveys that go out to the patients together with the wearables to see if we can assess, but they go out together with mood assessment and sort of cognition assessment. So we don't necessarily have projects that are focusing on specific diseases as are known, but are more about the mental well-being, mental health of the individuals that are part of the studies. And of course, we have one project for cancer predisposition, where we also try to assess stress in the patients and their parents. And we have it's a wearable project. It will not have a lot of data, but just to see what's happening. And it seems to be helping already, because sometimes the parents are saying that they're not in a good place. And so we have a special designated person who can actually call the parents and follow up to see that they are okay. Because my understanding is that with a lot of mental health issues and specific sort of thoughts, reaching out to the person to help and to offer help goes a long way. And so this is sort of some of the studies include that component, and I'm very happy that we're able to help, at least in this way now.
That's great. Thank you. Shazia, do you want to ask your question? And then I have two hands up that we'll go to next about race and SES bias in AI. No, okay. So that was, did the models adjust automatically for different patient populations was the question there. And I don't know if you have something brief to say about that, and then we'll move to Aisha.
So several things. The example that we got from UCSF is they were able to do it because they actually collect ethnicity information. You know, in Canada, they don't. Because they say we don't see color and everything, but we need to be able to assess bias. I think it's a very dangerous admission that people have done, right? Because even if people don't mean to, they sometimes, the medical science actually has not always considered different backgrounds of the individuals and is not catering everybody equally. And so we have those biases baked in the data already. So it's very, very important for us to be able to test that. So we test it using some auxiliary information, etc. But the reality is that in a lot of cases, especially at hospitals right now, where they don't collect that data, we are not able to test. The SES information we can cross-reference, and we've been using that at points. But we basically try to identify any subpopulation on which our model does not perform well. And that is something that we do for every single model. And we have a pipeline for sort of testing that.
Great, thank you. I'm going to go to Jingyi first, Aisha, because Jingyi has not asked a question yet.
Thank you so much, Kelly. Thank you, Anna, for your great presentation. I really enjoyed it. I have a general question for the students' background in your lab. And I was wondering, like, the students in your lab, they are more from a background where they have a very strong computer science background, and they're interested in healthcare, medication, so they come to your lab, or they are mostly from a very strong healthcare background, and that they are interested in applying artificial intelligence in the domain.
So most of my students are computer science students with interest in healthcare. However, I've had people with, I've supervised clinicians as well. One of the students that I have co-supervised is now a practicing doctor, actually, no, two practicing doctors. One is a gastrointestinal specialist, and one is Devin Singh. I co-supervised his master's thesis. Of course, he did a master's in computer science, but his background was in medical field. I am supervising an MD PhD student right now. So, and I've had several economists over the years in my lab who are also, of course, very technical. But it's a lot of times the key is to have a strong computational background, and then we work very closely with the clinicians to have the expertise. I am starting a program though at U of T, a master's in AI in healthcare. I don't know when we'll be able to start. We are hoping to start enrolling people for this next September, but you know, it has to go through the appropriate approvals. But this is one of the things that I'm passionate about. This new master's in AI and healthcare will take people from a variety of backgrounds, both computational and medical biology, to be able to build expertise and teams of people who are very, very fluent in AI space.
Thank you so much.
That sounds like a very exciting program coming up. I noticed that there's a question from Negin in the chat about the annotation data in the cardiac arrest study. Do you want to
Yeah, sure. Yeah. Hi, Anna. My name is Negin. I'm from Deloitte, Germany. I have a question more in a technical way. I'm wondering how the annotation of the data is done in the cardiac arrest study that you did.
So right now, all of so we have actually two ways that the data is annotated, or at least some of it. Cardiac arrest, we have from the clinical records, but we also have clinicians in our team that went through some of the data and annotated it with sort of events, saying this is this kind of event. It's a small portion of the data, but still it was helpful for representational learning projects that we've done that I did not talk about. In fact, around cardiac arrest, we have maybe 6 projects and papers of various sort of answering various questions. But I'm looking forward to this risk annotation, which will be done through this the human-computer interaction tool that we have developed to specifically collect the assessment of risk from the clinicians directly.
Okay, is it going to be published freely, or?
The tool?
Yeah.
Good question. So because my area is not HCI, I more focus on publishing the machine learning papers. The HCI tool would be Would be nice if it were published. I have to talk to Fanny about that, my HCI collaborator.
Okay, cool. Thank you so much.
We will publish. So we've been publishing in this area. Sanatani Kabuni, I can actually type it into chat, is the first author or last author on many of the work around the cardiac arrest, and we've published already about the pipeline and some about the interface, but we need to publish more on that. So she's leading the project. She's yeah, my senior PhD student.
Great, thank you so much.
Great. I'm wondering if Margarita would like to unmute and ask your question about the data, raw data feed.
Oh, yep. Hello. Just a quick question about the actual methodology that you use, because you mentioned that you prefer to feed the raw signal rather than doing signal processing because it helps to better generalize. And I was wondering, so that the methodology that we have concluded now is to take the raw time series and feed it to an answer, I suppose.
That's correct. We don't have a separate stage for processing. We did before for pre-processing, sort of forward carry and all of that. And we stopped doing that. What we do instead is the masking. And mask as one of the, the substructures of the deep network and the weighting of that.
Because it gives you better results when you're trying to generalize. And
that's correct. So it gives better results when you try to generalize because you're not making assumptions about the signal that is missing. So that's been very helpful. But also it's a simpler procedure for deployment.
Oh, that's true.
One model.
So when you're trying to put it in a smaller device, it's easier. Yeah, makes sense. Thank you so much, Anna.
Lots of people in the chat, and I'm not sure if everyone is still on. I'm wondering if Mary has a lot of questions in the chat. Mary, would you like to unmute and ask one of your questions? Maybe Mary has dropped off. So the other one is S. Battiston is the only name on there. Would you like to just introduce yourself and ask your question?
So the question that I wanted to ask was about if you have introduced any sort of explainability in your models to help physicians make the decisions about the suggestions that the model are making. So to help the physicians make, let's say, a more conscious decision if to trust whether the prediction of the model has to be trusted or taken into account or not, because I can figure there might be some situation, especially when there's a lot going around, where maybe you have to make a quick decision, and having that kind of help, so knowing how the model took that decision specifically might help in considering the suggestion that the model makes, or just discard it and proceed as usual.
Two things. So first, I just posted a paper on explainability and the pitfalls of the current explainability models that they don't really explain what's happening in the model, but people think that they do. There were several studies out of Microsoft by my colleagues to say that people tend to overtrust models that they think they understand. So, for example, people were saying simpler models, right? But the simpler models, they think they understand. So what this overtrust leads to is that in the end, they accept the mistakes the system makes, even if they would never make such a mistake themselves. So there are studies on that. So that's with respect to explainability. So we have to be extremely careful about how we use explainability. Now, we do actually have an explainable model. It's called FIT. It was published maybe NeurIPS a couple years back. I can post that link as well. So for the cardiac arrest model, we actually have a counterfactual model that we have developed. I actually almost put that model into the presentation just because it's explainability, but I didn't. So a lot of times it's very interesting about what clinicians actually want. Oh, we actually have a paper on that too. We did a survey of what clinicians want. That's what the paper is called. And so asking people about what they want to see. And in terms of explainability models, they don't always require this, and they basically, the clinicians fill in the why whatever's happening is happening. Now, I am hoping that we'll be able to deploy our explainable model, but if they're not looking to use it, if they don't need it, then it's just a sort of another model that somebody has to monitor and maintain. So I'm not sure about explainability models. Now, there are some models that are actually part of the where you can use the explainable, well, part of the model is explainable as GAMs, right? The generative additive models. And we had a whole bunch of research on that, but they don't perform as well in this time series space that we've been working on. So we ended up developing our own tool. So the answer about explainability is that it is not obvious that it's always needed, that it will be used, and that that it actually should be part of the system. So the jury is still out. But I encourage people to work on such models, because this is a very interesting machine learning problem in itself, and where we need to use them, it would be nice to have such models available.
Thank you. I noticed that Kira Karim, your hand was up. Do you still want to ask your question?
Hi, yeah, sorry. I'm sorry I can't put on my video right now. I just am on the go, so I don't think it's going to be a very good angle for myself. I just wanted to say hi. Thank you for the talk. And actually, I work at CDL, which you might recognize the pink photo. I work in the AI stream, so I have a more general, I guess, business focused question on AI at scale. So one of the things that we focus on is basically how AI is at its most optimal when it's being at scale. But do you believe that in order to validate technology and get the adoption from the industry, it needs to be de-risked on a smaller scale before it can be then widespread into an entire industry?
No, I don't think so at all, actually. I think the risks, I don't think we're de-risking by showing it on simpler problems, because on simpler problems or less risky problems, you use a different type of model, different type of methodology, and it doesn't really tell you anything about the model that will be developed for a high-risk application. So I think we can lull ourselves into thinking that we've de-risked things, but I don't think there is a real way to de-risk things. I think we just have to be extremely vigilant developing models for the very high risk setting and deploy it in a sort of highly monitored scenario where there is sort of always the backup, right?
Just an extension off of that. One of the reasons I asked this is because currently, and you might know Jay Agarwal and Abby Goldfarb, if you guys are part of the University of Toronto community, they're focusing on something called system solutions versus point solution. And the idea is that a system solution is only really valuable when it's at scale, and they parallel this to electricity and the adoption of electricity into the world versus AI, and how electricity really was at its most optimal when it was put and able to change the way that systems run, as opposed to just focusing on one part of a system solution, which is what AI at mass is currently doing. Anyways, the reason I asked that is because one of the biggest things of that being a solution is that in order for it to have most value, it's at scale. But one of the things that I've recognized is that sometimes one of the things I noticed from this talk, I would say, is that you believe that validation has to come from potentially like a prediction at a point as opposed to prediction at scale. And so maybe touching on what that validation looks like for the models that you use is also helpful for me to understand essentially what steps of validation you require for your models to have in order to then be deployed.
So we have this is actually a project in development. We have published on this a bit, but it's an evolving field, and the way that we do it is we first try to deploy it in a way that it doesn't affect clinical flow. We call this silent trial. So it runs in that stage for a while to see that it doesn't deteriorate, that it captures all the corner cases, that nothing comes out that we didn't expect. Then we have a plan for some kind of a clinical trial, sort of A/B testing type, where we show it to some of the clinicians and not the others, and see how it affects things. Now, I have some colleagues who have deployed things in the wild in hospital systems who say that all of the A/B testing and it's just never sophisticated enough to capture all of the things that you would want to test about an AI system. I think in Canada we are sort of leaning towards having such testing as part of the clinical flow. Again, depending on the risk of the system, right? As you mentioned, if it's predicting census, then it's not really the same as predicting the risk of a patient deteriorating, where you suddenly throw all the resources to help that patient, and that really affects the clinical flow. So these are some of the things, and we do have some of the. So even in critical care, we actually have a tool that identifies artifacts, because how often patients' blood is drawn shows up as an artifact in the signal in a series, and it's sort of fairly easy to detect very accurately, but how frequently it happens is an indication of deterioration as well. So it's another way to sort of have a lower risk system to show what it does and how it affects how the patient is doing.
Great, thank you so much, Anna.
Thank you so much, Anna. We're running right at the end here. There was so much discussion. It's such a sign of an excellent talk. I've noticed that Aisha put one last point in the chat, and I just thought if you wanted to maybe address any advice you would give to women in the field just before I bring things to a close.
I think there isn't something transformational that I can say that the women don't already know, but embracing yourself. And one of the things that really helped me is not to ask questions, can I do this? Am I good enough? Because no, I cannot do this and I'm never good enough. But do I really want to do this is the right question to ask. Is this something that I feel passionate about to see it through is the right question to ask. And so, and when you see something that doesn't quite feel right, maybe it's good to speak up, maybe to say, well, but why? Right? You don't have to be, like, I tend to be somewhat confrontational sometimes. You don't have to be, do you, right? But the point is that if something is not right, and if people are not considering women, it's not just you, right? It's others as well. And then you can ask, but why did you make this decision? And just, you know, have this conversation to try to understand where it is and maybe pinpoint solutions to some alternatives to some of the decisions that have been made. And then it's on them. So disassociating from the outcome sometimes really helps to make a point and to engage in a discussion and say, okay, I've done what I could do in this area. I'm happy to keep moving, but this is what I could do. So I think it's really important to find comfort in the questions that you ask and not to take yourself out of the equation. I find so many women take themselves out of the equation, out of the competition, out themselves. They think, actually, I don't think it went well. And say, well, actually, it went really well. So the perception of the women and being hard on themselves is so strong, and in the students that I see, and I was floored. I did not imagine this, and I tell this student that she's really good, and she says, "But no, I'm not." And I'm like, "Why don't you take my word for it?" I've seen a lot of students, and you're amazing. You can do all kinds of things. Let yourself do them. Like embrace what you enjoy, and. It seems that a lot of women have to step over a huge obstacle that we put ourselves. And it's okay not to be the smartest in the room to speak up. It's okay. I'm surrounded by people who are way better, way smarter, but I bring something in too, and that's okay.
Thank you for sharing that.
I just love the way that ended. Thank you so much, Anna. It was an extremely engaging presentation and amazing discussion. Thank you to all the people who posed questions. I'm sorry if I missed some of you. There were so many. I just want to, someone in the chat said, Niwat Visser said, thank you for your amazing talk. Your expertise and passion for helping people really came across. It's very genuine and it's very contagious. And I feel that now. I feel like I can conquer things as I walk away from your wonderful talk. I want to just remind everyone that there's more coming in our series. So please visit Schwartz Reisman Institute's website and follow us on Twitter at Toronto SRI. Thank you again, Anna, for a wonderful talk.
Thank you very much for having me. It's been my pleasure.